All right. Good evening, everyone. This is Dr. Jeanette McLean. Welcome to Expect More from Your Materials. Hopefully, everyone can hear me well. You won't be able to see me. Apparently, there's no video feed. So, hi. I promise I'm not in my pajamas. I even put real clothes on, makeup, but oh well, I guess you don't get to see me. But anyway, thanks so much for coming. I'm Dr. Jeanette McLean. I am a board certified pediatric dentist in private practice where I am an owner. Um, Here's some of my background information. I don't want to spend a ton of time on it, but basically graduated in 2003 from the University of Southern California for dental school. I did my pediatric training in Las Vegas at the Children's Hospital there, and I am in full-time private practice. And disclosure is important to tonight. I will receive an honorarium from GC America for giving this lecture tonight. So thanks to them for sponsoring this. And greetings from Phoenix, Arizona. It is super hot. It is sizzling. That's my saguaro in the front yard. I have no idea how tall that thing even is, but it's a big one. And it's super hot. It's monsoon season, so it's even a little humid. So if you're somewhere with better weather, I'm jealous. So this is a little bit about me. I'm a mom. I'm a pediatric dentist. People have come to know me as being a big advocate for minimally invasive dentistry. It's something I'm very passionate as a mom and as having a daughter who had surgery for dental care as an infant. That's my daughter there on the left. That's little Sabrina. So that's kind of how I fell into the world of speaking, kind of by accident. But it is a topic I'm passionate about and found that I really enjoy this. So thanks again for joining. So this is expect more from your materials that we're going to talk about tonight. This is something that really in the past, gosh, probably 5-6 years that I've really been on this journey of trying to do more minimally invasive treatment, I really changed the way I think about myself as a provider, as a pediatric dental provider. Initially I was really focused on, maybe this is a product of dental school, but, doing the perfect prep, making the prettiest restoration, doing the best color shade. Like I was really into the remodeling and the carpentry side, but now I'm realizing there's so much more, that the mouth body connection. I am I just a carpenter for teeth? No, I'm not. Neither are you. We're really the physician of the mouth, and we play a really important role in our patients' overall health. And we can't treat all patients the same. Each individual patient has unique needs and desires and complexities. and that's part of the challenge, but also kind of the part of the fun of what we do. So my goals for this presentation is to have us all thinking less like a carpenter for teeth, drilling and filling, but more like a physician for teeth. How can we make our patients healthier? How do we get their teeth healthier, the saliva better, et cetera, like a physician of the mouth. So I want to review with you new options for prevention and remineralization. And then talking about restorations when we do have to do the restorative part, but doing more than just restoring teeth, using products that are antimicrobial and that can remineralize tooth structure, et cetera, because that's what I get geeked out about and really enjoy. So I like to think of the products that I use and the materials that I use like medicine for tooth. They're doing more than just plugging a hole. they're healing the tooth. They're desensitizing. They're remineralizing. That's what I'm going for. So many challenges to us as dental healthcare providers, whether you're a dentist, a hygienist, an assistant, a therapist, whatever your role is, we face some common challenges. Here's some of them. I saw a lot of the picture on the top left today, really every day in a pediatric office, but, poor behavior from the patients, poor compliance, just eating junk. For sure, I'm seeing way more cavities than ever in my career post-pandemic as people are coming back to the dentist and they've been stuck at home with free access to the pantry and just snacking all day, and routines have kind of gone down the toilet for a lot of my patient population. just cavities galore. I imagine you guys are probably seeing that too. We struggle with issues like recurrent caries around existing restorations. Isolation can be a nightmare, whether you have a big gagger or someone with heavy saliva or whatever, or especially in pediatrics, it feels like there's spit everywhere. And then post-op sensitivity. These are some of the struggles. Now, as far as prevention products and things we can use to help our patients and overcome some of these challenges, of course, we all have our favorite products that we use. Like these are the obvious things. Like I've got my favorite toothbrushes, my favorite toothpaste, et cetera, et cetera. And sometimes it's like a revolving door of what, maybe I'm using one this time or something else another time. But I really want to think more of just cleaning teeth, or I want to think beyond just fluoride. Like those are the things we already know, and those are the things that are obvious. A lot of people know I love silver diamine fluoride, so of course I had to stick that in there too. But these are kind of like the obvious things: fluoride, varnish, mouthwash, different kinds of toothbrushes, yada yada. But let's think beyond that. So the first innovation or thing that I want to talk about would be full mouth remineralization and desensitization, but without stain. I mentioned SDF. Of course, one of the drawbacks of that would be stain. So let's say you have someone with sensitivity everywhere, you're not using it like varnish. It's not something you want over the entire mouth. So my favorite product for this is MI Paste and MI Paste Plus. So I don't know if you're using these yet in your practice, but this is what we carry, and I highly recommend it. And what MI Paste is, it's a topical cream that releases bioavailable calcium and phosphate and helps increase its presence in the saliva. And that, of course, is how we can naturally remineralize our teeth. And, saliva is important. Some patients don't produce enough saliva. Some patients' saliva has a poor buffering capacity, et cetera, et cetera. And these are the things that can help contribute to or exacerbate caries or sensitivity, et cetera. So MI Paste contains recaldent, which is casein phosphopeptide amorphous calcium phosphate, or CPP-ACP for short. And then what I call plain MI Paste is the one that's fluoride free. We see more and more patients now, for whatever reasons, where they don't want or they prefer not to use fluoride. And I definitely at a new patient exam, I'm not one to argue with them about it. We make note and we respect that. So there are more people who prefer not to use it. We also see a lot of little kiddos, and we do worry about them swallowing excessive amounts of fluoride. So we want to be conscientious of that. So sometimes we have kiddos that maybe are just 1 or 2 and they're still nursing, and maybe they're getting white spots, and perhaps this parent is concerned with the use of fluoride. We at least want them doing something that's going to help remineralize their teeth. So MI Paste is a great option for those little ones. We also carry MI Paste Plus, which is 900 part per million fluoride, so typical to your over-the-counter fluoride toothpaste. So not overdoing it, doing a nice therapeutic dose, but also containing the CPP-ACP or recaldent. So benefits are relieving sensitivity. It's great for prevention and remineralization. It's non-irritating for xerostomach patients. So for, let's say, your older patients or patients on lots of meds. And it's safe for lactose intolerant patients. However, it is contraindicated in patients that have a true milk protein allergy. So they're allergic to casein. So I love the new tubes that I'll show you in a little bit. They actually have the cute little cow cartoon on there. I thought that was really clever because it just kind of sticks out. So for example, here's one of those little kiddos that was still nursing on demand. The parents were still kind of not so confident in using fluoride products now. Now they do, but back then it was still kind of, so you see all this decalcification that he had and some lesions. So this is where I could really deliver patient-centered care, where I could decide, what are the goals of this family? So they were less concerned with cosmetics and more concerned with doing minimally invasive, what would be the easiest on him. They didn't want to sedate him. So of course you could go the route of doing sedation and beautiful white zirconia crowns. Absolutely. And we have families that choose to go that way, and that's fine. But in his case, I did offer SDF, but I don't want to make a mess of his teeth either. I mean, I could have painted it canine to canine, but all of that would have stained heavily, which sometimes the kids don't mind. I mean, I have patients where I do put it everywhere and they don't really mind, and other kids are more sensitive of it. But in his particular case, I was able to target treat the cavitated lesions with SDF and arrest and remineralize those. And then the smooth surface white spots, like the non-cavitated lesions, I had the parent just apply MI paste every day, and they were really good about doing it, very compliant. And, big picture, 3.5 years later, nothing bad happened with these teeth, nothing abscess. We didn't have to do anything more than that. And now he has this nice, healthy, permanent teeth coming in. He's super cute. So those were not extracted, those naturally exfoliated. And this is just recently, and he's still skittish about coming in. So in fact, I had to take a selfie of Woody, his little Woody doll, before he would let me take a selfie of him. So like you can see how he's kind of peering under the sunglasses, like, these kids. He was playing hard to get. In general, I do recommend prescription strength fluoride toothpaste for our super high risk patients, and especially those in fixed orthodontic appliances, right? I definitely recommend that. However, there is controversy with the use of high concentration fluoride toothpaste in patients with active white spot lesions. Reason being, while a high concentration of fluoride will help to arrest those spots, meaning block further mineral loss, it also will block natural remineralization. It will hypermineralize the outer layer. So then calcium and phosphate from the saliva can't get back in. So the white spots will not reverse, like they won't go away. And even worse, sometimes as they hypermineralize, they can also pick up different organic debris and stain and look yellow or brown and really become unsightly. So in the presence of active white spot lesions, you're really better off using a product like MI paste. And knowing this is also part of how the concept of a protocol called Etch plus MI paste came about, meaning that if you have a surface where it cannot absorb the calcium and phosphate, whether it's hypomineralized, or in this case, this is a congenital enamel defect, you can use your conventional 37% phosphoric acid etch the surface to help open the pores of the enamel, and that can help absorb the calcium and the phosphate from the MI paste. So that's what I'm doing here in the Etch plus MI paste protocol. It does take multiple appointments and using it daily at home. So like this kiddo, we did 5 rounds of the Etch plus MI paste protocol, and he had a nice result. I just did on it 8 and 9. And then this is 6 months after. He definitely needs to still improve his hygiene. Let's not try to skirt that. But huge improvement doing something extremely minimally invasive. Like I did this for free for him because he couldn't afford ortho. There was no interest in veneers, and certainly we wouldn't want to do something like that on such a young man, but it really was a nice confidence booster. So if that interests you, I do have a step-by-step technique video available on YouTube. My channel is Affiliated Children's Dental Specialists, and you can watch how to do that step by step. Tonight we're talking more about the materials themselves and less so much about the clinical technique. So in Australia, MI paste is actually called tooth mousse. And I do like to share that information, especially with parents, because my young patients are too young to get what mousse is, but that's like what we would put in our hair in the 80s, and scrunch up our perms. So it gives volume. So it helps them conceptualize how the MI paste and MI paste plus is that extra step, like you brush and floss your teeth, but then you also put on the MI paste. So I tell them to put it on their teeth like a lotion before they go to bed. Now, everyone isn't necessarily compliant. One thing I'll say about patients that have post-orthodontic white spot lesions, it's like they've already demonstrated they're not compliant. So an extra step can be challenging to some patients. So another option that you have is MI paste 1, meaning one step. So instead of having separate toothpaste and MI paste, it's all combined together. So you can clean and protect teeth in one step. So in that case, you're having better compliance. So that's great for patients that have sensitivity from whitening, like doing home bleaching, like I do Crest White strips, for example. So I like MI paste if I'm whitening because it's going to help decrease my sensitivity or keep it at a minimum. But it will also do the other things that MI paste does. So the remineralization, it helps patients that have enamel erosion and wear. And then, of course, caries prevention. And I mentioned the sensitivity. So this is their newer product that's coming out soon. That's going to be MI Paste 1 specifically for kids, because a lot of kids are like, I don't like mint, it burns, it's spicy. So this is MI Paste 1 for kids, and the flavors are going to be bubblegum, blue raspberry, and cotton candy, and they're really good. My kids got to try them, and I tried them myself. So definitely check this out. Now, when I've done the Etch Plus MI Paste protocol, I have used both plain MI Paste and I've used MI Paste Plus, and I did have success with both. Remember that it's just 900 part per million fluoride. So it's not an excessive or extreme amount of fluoride. So to get more information on MI Paste, I would encourage you to visit GC America's website. I also have on my website, I guess that didn't work, but I have a link to MI Paste. There's a whole page that shows the video of how to do it, and as well as downloads of these different references where you can see other people's protocols on how they use etch with MI Paste to get rid of some of these congenital enamel defects. Now let's talk sealants. So I'm a huge fan of glass ionomer sealants. In the past, we had exclusively used resin, and these were some of the challenges that I saw. So it was difficult to achieve ideal isolation, especially in little kids. It was very time consuming when you had to do all this ideal isolation. We had a lot of patients that were too little or too afraid to even tolerate the isolation necessary to do a sealant, or sometimes the stuff looks scary, like this etch syringe looked like a shot. And sometimes, rare, but there were a few instances where my dental assistants accidentally got etch on the patient's face and they got a chemical burn. I actually saw that in a post. If there's anyone listening tonight that's in the Mommy Dentist in Business Facebook group, hi, first of all, hello. But there was a post tonight about that specifically, where someone had gotten etch, or actually it was the dental assistant got etch on the patient's face, and they kind of smeared it off versus like rinsing it copiously, and it burned the skin. And it's terrible when that happens, and you feel awful. And sometimes you don't even realize, like sometimes it was like on the edge of the tube and no one even noticed. So I don't miss that for 1 second. That's like one of the great things of switching to glass. So other issues where you can seal partially erupted molars with resin, and inevitably they seem to chip and leak over time and often had decay underneath. So it really got me thinking. This is probably 5-6 years ago, where I'm like, what's the meaning of life? What's the meaning of sealants? And I question, what really defines sealant success? Is it retention of the sealant material? That seems to be a common metric in studies on sealants, and that's a common mentality of dentists. Or is the purpose of a sealant to prevent caries? Well, I'm pretty sure it's to prevent decay, right? Like, oh yeah, it was like a light bulb moment. And what I was noticing in our teenage and college age patients that had existing resin sealants, that in time, especially the distal lingual groove or their upper molars, like my one and only cavity filling is on the distal lingual groove of number 15, where a resin sealant eventually fell off and it had leaked underneath. So here's a patient of mine where you could literally see the decal and stuff underneath, and often you can pick these off of the teeth and it'll be soft underneath. So we did switch to glass ionomer. We exclusively do glass ionomer sealants on all virgin teeth in my practice. The only teeth that will get resin sealant are ones that are existing resin sealants, and maybe we're adding to it because sometimes they will chip or break. But some of the benefits is really just the simplicity of application. It's a hydrophilic material, so it does need moisture to set, and you can do it in a moist environment. The material is biocompatible It will release and recharge with fluoride. Just even using a fluoride toothpaste will recharge the sealant. It's well tolerated by a wide range of patients. So kids that were maybe too phobic before or special needs, et cetera, we can get it done on them, especially because it can be done in a moist environment. You can use it on partially erupted molars, which is excellent because I'm sure you've seen, especially if you see pediatric patients where sometimes their second molars are coming in and they haven't even lost their primary molars and there's not enough space and they could sit partially erupted for a year or two or more. And it's just this food trap. So you really want to get a sealant, especially a glass ionomer sealant on something like that. It flows nicely into the pits and fissures, excuse me. And now this is a really important thing. See how I wrote there that wear and loss is not associated with caries. And I'll explain more about that, but that's really the what you expect more from your materials. And of course, there's different brands. I do use the Fuji Triage, which is available in pink and white. GC America has been making glass ionomer products for a century. So to me, they're my favorite, but of course, use the brand that you want. But they make a nice glass ionomer. They've been doing it for a long time, and I really feel they've perfected the material. So getting back to glass sealants. So if you're going to read one paper on it, this is the one I recommend. This is from the ADA journal. It's a systematic review. So this is huge with a meta-analysis. So we were looking at multiple studies and they found no difference between the percentage of caries developed, whether you use glass ionomer or resin. So at least at their equivalent. I personally think glass ionomer is better, and you'll understand as we go a little deeper into it. So these findings indicate that the caries prevention effect of glass ionomer based sealants is not associated with retention. Wait, what? Let's say that again. The caries prevention effect of glass ionomer cement-based sealants is not associated with retention. So let's say in time, a low viscosity glass might start to wear off. You don't see decalcification and decay. Now, with resin-based sealants, you can find decalcification and decay. So let's look at more at that. So in the same study, they mentioned how the risk of loss of complete retention of sealant materials was associated with the risk of developing caries occurrence for resin-based sealants, but not for the glass ionomer-based sealants. The explanation of this result was that small particles remained in the bottoms of fissures that acted as a fluoride reservoir, and that the slow release of fluoride enhanced nearby enamel remineralization. So even though you visually might think it's gone, or maybe you can't feel it, I honestly feel that the fissure grooves just feel smoother because it's still down in the fissure. So this is just demonstrating that by looking at a glass ionomer sealed tooth cut in a cross section. Some other little pointers from that is just the importance of that article is the importance of using the cavity conditioner, which is a weaker acid than your traditional etch, but that enhances the chelation and the chemical reaction between the calcium of the enamel and the glass ionomer. So, again, this is more like medicine for the teeth. It's more than just gluing something to a surface. And then this I thought was the biggest point out of that article, where I would hope, like the way I read this is really glass ionomer is better, but they found that it seems that glass ionomer based sealants with their lower technique sensitivity, good adherence, and fluoride releasing properties have an additive effect of being a sealant and fluoride provider for the prevention of occlusal caries. Therefore, glass ionomer cement-based sealants may be a good alternative to resin-based sealants, specifically in community procedures where there's limited equipment, no chairside assistant for the dentist or dental hygienist, and a considerable number of children at high risk for developing caries. So if you run a sealant program in a school or a mobile clinic, I really hope you're using glass ionomer sealants, because you really should not be using resin. But even in my office where we do have chairside assistants, we're using glass ionomer because it's a better material. You don't have to worry about water or saliva contamination or blood contamination. It's hydrophilic. So speaking of hydrophilic, but glass ionomer does better in a wet field. And who are we putting sealants on? Little kids. How easy is it to keep their tongue away or to keep it perfectly dry? Not easy. So like 10 years ago when I had a kid, I couldn't get a sealant on the way, and the parent was like, "Oh, I really want sealant." I used to have to explain to them like a bad sealant is worse than no sealant. So like if I can't properly isolate this, you're not doing someone any favors by sticking a resin sealant in a wet surface. Like you might as well give them a cavity. You're basically giving them a cavity because it's going to leak and fail and not be good. So as far as the techniques, I have application videos available on my YouTube channel. So I have one for your just traditional white triage sealant. And then also for the triage pink, this one being on GC America's YouTube channel. And speaking of triage pink, some kids just like having it, like little girls, especially like, oh yeah, I want a pink sealant, but it's especially popular for partially erupted molars. So in this example where I'm sealing this partially erupted molar on my patient here, and she's that example where she just doesn't quite have enough room in the arch for this tooth. And she had tons of restorations in her primary teeth. Of course, now those have exfoliated. But high risk for caries. So I wanted to get sealant on those as soon as possible. So the pink is great. So it has the color indicator. So that's another reason why people like it, is because you can clearly see that it's there, especially on the partially erupted teeth. You can command set it with a curing light because it will absorb heat. So that's a trick specifically with pink. Some people like it for their temporary restorations or for toothbrush abrasion, so down along the gum line because it is pink, or exposed roots. Now, on a cooperative patient, you can do all 4 first permanent molars with 1 capsule of triage in under 5 minutes. So the teeth are protected, the parents are happy because usually we're doing it right then and there at their exam. Whereas before they would have to reschedule and come back and we'd block out 30 minutes or 45 minutes. And sometimes they would no show or they would cancel last minute or they would come in and then misbehave and we couldn't get it done. Like a total waste of time. So the kids are happy because it's fast, easy, and painless. It saves on chair time and supplies. So it is great for production in that sense. So really everyone wins. So I highly recommend, if you haven't tried them, to definitely give glass ionomer sealants a chance. And the way that I explain it to the parents is it's like medicine for the teeth. So I'm not just gluing a plastic barrier, I'm putting something that is going to release minerals and leave behind stronger, more acid resistant enamel. So that tooth is less likely to get a cavity. And I like that. And I like that too. So now there's an improved version of Fuji Triage where it's Triage EP, and the EP stands for extra protection. And what they've done is they've added in the Recaldent ingredient. And you already know that from me talking about MI paste, that's going to increase the bioavailable calcium and phosphate. So not only will you have fluoride, you're going to have calcium and phosphate. So this is just reiterating that. So it's going to seal and protect, all the normal things that a sealant does, but it's going to release 6 times more fluoride than any other sealant. It releases fluoride for up to 24 months to help prevent decay from acid and bacteria. It also helps to inhibit biofilm formation and obviously prevent decay from acid and bacteria. But specifically comparing the different products, like if you compare to a composite or a resin, there's really no protection to the adjacent enamel, right? It's not really doing it because this isn't chemically inert. And once it starts to leak at the margin, now you have a food trap or a biofilm trap. So triage is nice because it is offering, by the release of fluoride, protection to the adjacent enamel. Okay, nice, I like it. But now here's EP and you're enhancing the protection by adding in the calcium and phosphate, and you're just seeing better protection on the adjacent enamel. Also, it helps to reduce the biofilm volume by 50% and the thickness by 66%. So you're just seeing less bacterial colonization on the surfaces. Pretty cool stuff. Now, I know here I'm going to get controversial. So I have heard people talk about using SDF as a sealant, or like, oh, put it on newly erupted first molars like a sealant. Please don't do that, because this is what can happen. So this, there's no caries here, but this is just putting SDF on a virgin newly erupted tooth. And sometimes you can get stain on immature enamel, or maybe there's subclinical caries, but this is not good. So I don't recommend using SDF like a sealant. I like using a sealant as a sealant. Put a glass ionomer sealant and you'll get remineralization without stain. Okay, so AABD has come out recently talking about proper use of the SDF code. So 1354 is typically what we think of using SDF for caries arrest. There's a new code that was introduced this year, 1355, caries preventive medicament application per tooth, but for secondary, I explained that wrong, excuse me. So 1354 is like already an existing cavity, so caries arrest, right? But 1355 is caries prevention, so using it for primary prevention. So like if you were to use it like a sealant, but you're not going to because you don't want it to look like that. But they said that they don't recommend that. Their reason being because of the limited evidence. I mean, there absolutely is evidence that SDF can help prevent caries, but usually it's when you apply it to a carious lesion, you see less caries on other teeth. It doesn't tell you they didn't test, painted on all the virgin teeth. No, we're kind of extrapolating that, right? And then this is another recent publication where they said that too. They're not supporting the use of 1355 primary prevention of SDF. They only support 1354 caries arrest. Now, for prevention, you bet there's plenty of evidence that, like, this is the cover of ADA Journal where they mention how SDF can help when you apply it to exposed root surfaces, a really high risk area in older adults. It's simple, inexpensive, and an effective way of preventing caries initiation and progression. That's the perfect example of where to use the code 1355 SDF for primary prevention. But please don't use it on a sealant, as a sealant on a little kid's brand new permanent tooth. Put a glass ionomer sealant, please. And here's the perfect example of this. So this is March 2021's ADA Journal, looking at this amazing 6-year program in public health, where they went into elementary schools and did essentially a oral hygiene and sealant program. So they did a cleaning, they did glass ionomer sealants, they used Fuji 9. Okay, so like basically a filling material, so a higher viscosity glass that's going to be more wear resistant. They did interim therapeutic restorations, fluoride varnish, toothbrushes, or pass them out, fluoride toothpaste, oral hygiene instructions, and referral to community dentists as needed. And they help to reduce the prevalence of untreated caries by more than 50%. Very successful. So just by adding in the glass ionomer sealant. So please, I hope if you're doing these type of school outreach programs, please use glass ionomer sealants on permanent first molars. And now I will step off my soapbox. All right, so now let's talk about glass ionomer restorations. I love doing those as well. Similar challenges when I used to do resin restorations. Like, I almost exclusively use glass ionomer restoratives, period, in my office. The only time I will use a resin restorative would be, let's say, a chipped front tooth, like a chipped permanent front tooth, although even some of those I've done with glass. Like, I'll show you what I did with my daughter. Or maybe, limited. It's very, very selective. In general, I'm using glass ionomer. But often with resin, especially if you're doing a filling, you need some kind of surgical preparation, which is going to need some local anesthesia, isolation. Can be hard because you got to put the rubber dam. Sometimes they can't tolerate a rubber dam. If you get blood or saliva contamination, it's going to fail or stain at the margin. You see a lot of recurrent caries as the margins start to leak and stain over time. And typically under failed resin, you see mushy caries, right? Sometimes there's issues with post-op sensitivity. Let's say you accidentally etch the dentin. Let's say maybe your curing light is weak, or whatever it is, just stress on the tooth. You might feel post-op sensitivity, especially larger ones or multi-surface. And in many cases, if you're treating children, you might have to sedate the patient to get the type of isolation that's necessary to properly place a resin restoration. And not everyone wants to sedate their kid. And if there's alternatives, like, we need to mention them. It might not be for everyone, but at least mention that they're an option. That's what we're morally and ethically inclined to do, is explain when there are other options. And unfortunately, many US trained dentists are still what I like to refer to as bonded on us. Like, we love resin, and it's hard to get away from that because it's so ingrained in our training. And that was definitely my situation of where and when I went to dental school. Like, we used resin for everything, and like, I never got to use glass ionomer restorative. So it was a lot of continuing education and self-guided instruction to get me to this point. But I used to believe in complete caries removal. We were taught extension for prevention, like drilling out all these grooves. Like, I cringe at what I used to do because it was so unnecessarily invasive and detrimental, honestly, to a lot of teeth. I could have been much more conservative. Or drilling based on the color of a tooth, like, oh, it's brown, it must be decay, let's drill it all out. Versus actually using hardness as a whether or not to quote unquote drill something, right? You should be based on hardness. So for a lot of us, it's like, we got to have Yoda as our Jedi master. We got to unlearn what we have learned. And it's really hard. It's really hard. But contemporary concepts for caries tissue removal is to avoid invasive treatments whenever possible, and instead control the activity of the biofilm and the lesion. Again, think more like a physician and less like a carpenter. Think about that biofilm. Think about remineralization. Think about bioactive restoratives. Now, looking at the AAPD handbook or reference manual, they tell us, or we know now, that there's evidence from randomized controlled trials and systematic reviews that incomplete caries excavation in primary and permanent teeth with normal pulps or even reversible pulpitis, either partial one-step or stepwise two-step excavation, results in fewer pulp exposures and fewer signs and symptoms of pulpal disease than complete excavation. So this often is an easier concept for pediatric dentists to grasp, because we get that indirect pulp caps work great. They actually work better than a conventional pulpotomy. So if you don't know a whole lot about minimal intervention dentistry, I recommend looking for papers and textbooks by Dr. Jo Franken, who's from the Netherlands. That really opened my eyes to this concept. There's tons of papers. We never would have time to go through them all. Like, a lot of these I talk about I have another on-demand webinar you could get through Elevate Oral Care's YouTube channel. But if you want to deep dive into this, and I'll show that on the final slide, but you can do art and have equivalent success rate, especially in single service restorations, as to just drilling and filling and putting resin or amalgam. There's lots of evidence for that. So I love glass ionomer restoratives. They're biocompatible. They mimic our natural dentin. They're really easy to use because they are hydrophilic. They have this antimicrobial effect. So we see a lot less secondary caries. It does release fluoride and other minerals, which I'll mention, and it has that superior marginal seal because it chemically bonds to enamel and dentin. I'll show you some images of that. So again, use the material you like. My personal preference, I love me some GC America glass ionomer. I love Equia Forte. I think more and more people are using Equia Forte and also love it. I call it the magical unicorn, but you can do bulk fill restorations, maximum fluoride release, better than some of the other brands. They've improved the wear resistance. So this is new and improved Fuji 9, but some people still love Fuji 9. So again, use what you like. It's your call, but this is what I typically use. And now they have HT, which stands for high translucency, which is more aesthetic. So similar to resin. That's what I'll actually use in the anterior. But in thinking of this superior chemical bond, there's actually what's called the chemical fusion zone. So if you look on a scanning electron microscope, you can see between the glass and the dentin, and there's no leaking at the margin. Like, they're literally cross-linked and they're one, and they have this super strong chemically fused zone, which is pretty cool. But there is this crossover of ions from the tooth, calcium, and then from the glass, you can get fluoride, which I've mentioned, but also some of them have strontium. And sharing is caring. I love Charlie Brown and Snoopy, by the way. Yes, my son's name is Charlie. But yes, sharing with your neighbors, we've known since kindergarten that that's nice, right? Okay. Well, when you look at these teeth treated with glass, you can actually find ions where there's no other potential source of them but from the restorative material. So it is uptaken and absorbed into the dentin. So in this example, they looked at fluorine and strontium ions that penetrated deep into the underlying demineralized dentin. And that pattern was consistent with remineralization. And the only source of that was the glass ionomer. Pretty cool. So again, it's like medicine for teeth. I'm not just filling a hole, I'm putting medicine on the tooth. There's tons of papers on this. And in the interest of time, I won't spend a lot, but here's another one. Less recurrent decay than amalgam after 6 years in permanent teeth. So it's a cariostatic material. In this study, they looked at secondary caries again, significantly lower incidence of secondary caries with glass ionomer versus amalgam. I mean, people love amalgam and talk about, oh, you barely get recurrent caries, but it is even better with glass. It also has caries protective effects for the cavo surface and adjacent teeth. So remember, sharing is caring. So you're helping the tooth and the neighbor. So again, it's like medicine for teeth. I do carry a variety of glass products. Like if you're new to it, I would suggest, like if you want a one size fits all, something you use to seal and fill, you could, I would go with Equia, but technically I use a variety. I use RMGI, like Fuji 2LC, I use the Triage, and I use the Equia. There's still a lot of misconceptions about glass, like people think it's going to wash out, yada, yada. It's temporary only. You can use it as an interim, but you can also use it as your definitive restoration. And there's a lot of evidence to support that. Like here's a paper looking at 10-year follow-up of these glass restorations and its ability to adhere to moist enamel and dentin without needing a bonding agent. Okay. And they're successful in class 1 and class 2s in a 10-year follow-up. Here's this very simple occlusal, which if you've never used glass, this is what I recommend to start with. You know, don't start with crazy multi-surface anterior teeth. If you've never picked up a capsule of Equia before, you don't do that to yourself. You know, it'll probably fail, and it's not the material's fault. It's just like you've never done it before. So start small. So here's a simple art occlusal. 3 years later, technically it's a smart occlusal because I did silver diamine fluoride first, but it's wear resistant, it's aesthetic, there's no preparation, no injections, nothing, no rubber dam. This filling is still going strong. It's coming up on 4 years. I'll have to get a new picture. I use it in class 2s. Again, start with class 1, improve your skills with it, and then you can start doing some class 2s. And this is a tooth with MIH, and it still looks beautiful. There's absolutely a learning curve. Give yourself some grace to practice with it. Practice on extracted teeth and a typodont first. Do those occlusals first. Work your way up and figure it out. Because I will notice in the online communities, people will complain like, oh, this happened, that happened. It's all part of that learning curve. And you have to understand, like once you can master handling the material, you'll be golden. Much of what I've learned on glass ionomer has been from Dr. Doug Young. So I highly recommend if you can seek out any articles or on-demand CE available for him. He just has so many pearls of wisdom on how to properly handle glass. So please, please, please reach out, or I guess not reach out, but reach out in the virtual sense and watch one of his webinars or read one of his articles, because he really is the man when it comes to doing great glass restorations. And I learned so much from him. Now, there's lots of tips and tricks. That wasn't really the point of tonight, but just really quickly, like if you are wanting to move to a class 2, I put a tutorial on my YouTube for how to handle them for class 2 restorations and not like break your box when you're removing the matrix band. Like there's a correct way to handle it and have success using the conditioner. I already mentioned that, not letting it dry out. using polishing stones with water spray, using the coat, all these things, and you're going to have great results. Typically, when someone's having issues, it's either because they're new to it or they're just not using, like they're skipping steps or they're drying it out, or there's usually something wrong that you could then fix and be more successful. Also, soft foods for 48 hours is highly recommended. Now moving on to anterior restorations for the last little portion of this, I recommend the high translucency, so Equia HT. There's a little more working time with this and it's more translucent. So in a mouth like this, where they drink soda all the time, bad hygiene, salivary dysfunction, you really don't want to use resin in a mouth like this. You're like shooting yourself in the foot. You need medicine for the teeth. So the glass ionomer is excellent. And you really can't even see the difference between, or where one ends and one begins with that nice chemical bond. This image is from Dr. Rella Christensen, looking that under a scanning electron microscope, where you can see how in time resins do pull away from the tooth structure. So I feel like resin in a mouth like that is like a squirt gun on a forest fire. Now, I've mentioned some of these type of studies before, but again, glass ionomer is associated with significantly better ability to prevent caries lesions. So like if you have a mouth like that with all the decalcification, glass ionomer is definitely the way to go if you don't want to get recurrent caries, because it really is like medicine for the teeth. Now, I have used it for chipped front teeth, like my daughter. I've shared this case many times before if you've ever watched any of my other webinars, but she chipped her lower incisor. She's spitty, she's wiggly. The dentin was exposed. I was like, my baby. So yeah, I use Equia, I use glass. And it's still growing strong. So now it's been 15 months. There she is at her volleyball practice. And I think that's pretty darn aesthetic looking. She's had no sensitivity with it. It hasn't broken. You really can do amazing stuff with it. I do atraumatic strip crowns. You know, if you're sedating a kid or you're in the OR, this is not the appropriate one for, like, use a zirconia crown. You can do your resin strip crown, so you have no, like, there's no chance of it chipping, especially if you're using zirconia. But in a situation where you have, say, I have a lot of kids who are like under the age of 2 or even under the age of 3, where the parents don't want to sedate them, or they're still doing the habit that made the decay, like they're still in a bottle, they're still nursing throughout the night, whatever it is. But I have to do something. I have to act fast and not just let that tooth rot away till it abscesses and then I'm going to extract it. So think of this like medicine, like a Band-Aid on the enamel. I can put glass ionomer in a strip crown form, like this little kiddo, like, and please appreciate how there's not a lot of tooth left, right? But I did strip crowns with Equia. Okay. Look at the PA. There's no abscess, right? But there's not a whole lot of clinical crown to bond to. I'm sure there's folks who'd be like, oh, I'm just going to extract those. But he's like 2. You don't want to extract their teeth, their incisors before the age of 4. It'll delay the permanent teeth coming in. Like, I wanted to save these teeth. They were asymptomatic. I did my little Equia HT Band-Aids, strip crowns, if you will. You can read a full article on it in the February 2021 issue. I almost said episode of Inside Dentistry. You can find this online on demand. I have it on my website and blog too. Well, then a year and a half later, he came in and sure enough, he chipped one of them. He chipped one. But remember how little there was left? Like, I'm sure we could all agree that it would be hard to retain anything on that. But I didn't just glue something on there. I put medicine on his tooth. Look at how much it remineralized. Look at how healthy his roots are. There's no internal resorption. There's no abscesses. There's no sensitivity. There's nothing. And hello, he chipped his bottom tooth also. So even they can chip their natural enamel, right? So of course he could chip my little Band-Aid, but this is hard as a rock. So hopefully this video will play. Listen to
this profession.
I'm trying to see if you can hear it go click, click, because it's hard as a rock.
Oh yeah. Can you hear it?
Yeah.
Rock solid. Hopefully you could hear that. But yeah, I mean, that was hard as a rock. So I just flowed a little more material over the front. And let's compare the PAs side by side. Look at how it truly, that glass healed the dentin and the enamel. Look at the remineralization. Look at how much more radiopaque it is. I think that's pretty cool. So the mom was super happy. She was like ready to explode pregnant when I first saw it. Like she didn't want to go to the OR and do a bunch of zirconia and spend thousands and thousands of dollars. Like she was so grateful to have this option. So a little more on glass as medicine. The amount of fluoride released to adjacent enamel is huge compared to resin. There's multiple studies. This is a systematic review. Like here's one 5 times more, 6 times more, 6 times more, 6 times. Like it's so much more. So we know it's like medicine for teeth. This is looking at fluoride release. This is from Dr. Christensen again. But Equia being the highest fluoride release, 3M's Ketac Universal is another good glass product. But sometimes people are marketing bioactive properties, and it's really just marketing, and they release very little fluoride. Like, look at how low we're just kind of flatlining down here, right? So glass is amazing for root surfaces. If you're treating older patients and you're not using glass ionomer and doing class 5s, you're welcome. You're going to be loving life. I hope you're using glass for surfaces like this, but it is just super easy. So I did this for my office manager's mom, who's medically frail. So I didn't need local anesthetic. You don't need a rubber dam. You basically clean the surface, apply the Equia. We only had A1 shade at that time. So obviously you could get a better shade. You could use HT and it'd be a little more translucent. You could get a gum color shade, like whatever you want. This is just, I'm pedo, I have A1. But they've been on there more than 3 years. This is back in January, this picture. So now they're more than 3 years, but that's pretty amazing. There's no recurrent caries. There's no wear. I mean, how long did that take me? Maybe 5 minutes. Like, why not? This stuff's awesome. And there's literature to support the use of glass over resin for class 5s. They're just significantly better than using a 2-step adhesive. And then in terms of recurrent caries and having to replace restorations, resin composite has a lifespan of about 6 years. And I've heard that before. I'm so happy to finally know, okay, this is the paper it comes from. But glass ionomer has a lifespan of about 11 years. And you're going to see less recurrent caries. It's wonderful for molar incisor hypomineralization, or MIH. And this is the one paper I would point you to that's open source and you can find it online. But this is a Brazilian study that used Equia and treated molars with MIH and had incredible success. But what I like specifically about this is it mentions a problem that I had always noticed earlier in my career and didn't understand it. Like, why was I getting so many resin failures on hypomineralized teeth? Well, it can't effectively bond to MIH affected enamel. So why are you using it on that? So glass is a significantly superior material for hypomineralized teeth. So whether it's mild or severe, maybe you want to add in silver diamine fluoride to desensitize it. You can read about that step by step in my Decisions in Dentistry article that came out in November 2018. That's on my website as well. Pretty much everything I show you can find either on my Instagram or blog or website. But more recently, GC America came out with this really nice resource for treating MIH. So I encourage you to download this. If you're an ADA member, you probably got it in an email blast where they did a partnership and put this out. But discussing ways to manage patients with MIH and how to identify, prevent, and restore. So be sure to print this out. I'm also using this for parent education. It's hard to explain this to parents. Sometimes they can't, like if it's way in the back, maybe they can't see it. Like I want them to understand what's going on and why it's important that they pay attention and do things like varnish, MI paste, sealants, coming in regularly, et cetera, et cetera. If you have a tooth with MIH and it's partially erupted, absolutely get a glass sealant on there. The sooner the better. Okay. You can do some minimally invasive restorations, even if they're interim. Like obviously stuff like this long-term is going to either need extraction or full coverage, but you can do smart restorations. You can do the Hall technique. We're running out of time. I think we have 5 minutes. But Hall technique, I am also passionate about. You can read my article in Dental Town on that. And I have a whole page dedicated to it on my website, which is kidsteethandbraces.com. but it's essentially this biologic approach to managing caries where you're just sealing off the lesion and protecting it from the cariogenic biofilm so it can heal itself essentially and arrest and not progress further to the pulp. And the pulp can lay down a protective layer of odontoblasts to seal itself off from the lesion. And, this is from the AAPD, but it's just ironic, people get so into like, well, it has to be this or it has to be that for my indirect pulp. Well, really, you can technically use anything and you can do indirect pulp cap. In general, they recommend doing treatment in these vital primary teeth with deep caries lesions to do it based on a biologic approach. And now some people get confused by that word because they think like, oh, like a biologic dentist. No, like working with the body, like letting it help heal itself. So, a tooth with reversible pulpitis or asymptomatic, it can heal itself by laying down those odontoblasts. So, and you can use pretty much any material that you want. My go-to would be the Fujisim too, and I use that in all of my stainless steel crowns. And so here's an example, MIH, I put a little SDF, these need full coverage. So I did 4 Hall crowns and I follow these patients for many years and it's clinically successful, but this is a great way to help avoid the use of sedation, especially in young patients and ones with MIH. So this ad kind of resonated with me, restorations that cross generations, because really from the pediatric patients to our geriatric patients and everyone in between, these materials are like medicine for teeth and have so many vital uses or helpful uses. So be sure to check out GC's website and resources. I mentioned my YouTube channel, Affiliated Children's Dental Specialists, but there's tons of clinical tutorials if you want to learn any of these things step by step. And for additional resources, I mentioned my website, kidsteethandbraces.com. There's all sorts of resources on there and downloads, links to on-demand CE, links to the video tutorials. I mentioned for the atraumatic restorative treatment, this is a free webinar on Elevate's YouTube. So check that out. And we have a couple of minutes for questions. So how much time between appointments for the etch, the MI PACE etch protocol? So usually about 10 to 14 days roughly. Okay. And then how much do we charge at our office for MI PACE? I assume you mean like the tube of paste or if you mean the etch plus MI PACE. Like if you watch the classes that I've done on etch plus MI paste, there's 3 different ways that you can calculate it. I think I'm quite sure I have that on my website on the MI paste page where you can download a handout that came from GC with 3 different suggestions on how to bill out for etch plus MI paste. Now, as far as the paste itself, it's really up to you. Some people order it and just give it to their patients. Like for example, orthodontists will just include it in their patient start bag, along with sometimes they'll give a toothbrush or whatever it is. So some people just give it like it's part of that whole patient experience and building good faith or goodwill with patients, or you could treat as like a commodity that you sell. I mean, some people don't want to have to sell products and collect tax. We do. I don't know if I'm allowed to say what we charge though. Whatever you think is reasonable for purchasing it. And, sometimes they're on a sale and you can buy some, get some, et cetera. Whatever is like reasonable or what you think is good. Okay. And someone has said, my doctor has his polish on MI paste after the prophy. Is there a therapeutic benefit or a waste of time? I mean, you really could just put it on there. I don't know. Now, I have polished it on during the etch plus MI paste protocol. So if that's what you mean, I have found it's more effective on some of the stubborn spots. So yes, in that scenario. If you mean just in general, you don't have to. Like I would put on maybe the varnish version, or they could spread it on their teeth just to improve the calcium and phosphate in their mouth, but you don't have to prophy cup it on. Okay. And then how do you decide between MI paste protocol versus etch bleach seal? in that case, it looked like there were some brown spots as well. He really didn't have any brown spots, but I have done some. Like if you go to the YouTube, there's a video of the etch bleach seal technique, and that kid legit had brown. I'm pretty sure he had fluorosis, but he had pretty dark brown. So if you etch and there's brown stain, you do want to apply a sodium hypochlorite, aka bleach, to help break down that organic debris so then you can rinse it away. Now, if there's porosity to the enamel or if they're a mouth breather, the MI paste protocol alone won't necessarily eliminate that. And that's a situation where you're going to want to either protect the enamel so that it can't stain again. So you could just seal it. But if you want something to penetrate deeper, you can do resin infiltration, because that will get significantly deeper than the resin for that you use with a clear sealant. That's like a whole 2-hour lecture right there. But generally speaking, yeah, if it's brown, I'll etch and get some bleach on it. Okay. Someone asked about Embrace wet bond sealant with fluoride releasing. That would be cool to see if they've studied them side by side to see what releases more. If something is resin and it has allegedly fluoride, I'm super leery, because the fluoride molecules don't really move through resin. And then someone said, is it better to use Triage versus Fuji 9? I would say the Fuji 9 would definitely last longer because it's a high viscosity. Now Fuji Triage is going to flow better and let you get more teeth done at once, especially on a little wiggly kid. So you really could use either one. Some people prefer 9, some people like Triage. If I'm doing restorative, I'll just use whatever restorative material. Like if I'm restoring an adjacent tooth with Equia, Equia becomes the sealant for the neighbor, etc. That paper that was in ADA and just a couple months back, that was Fuji 9 in that big 6-year study of the sealant programs in schools with like 6,000 kids. That was Fuji 9. And then this is good. Fuji Triage EP with Eucaldent on patients. If they have a true casein allergy and milk protein allergy, I would not use that. They should not have that. Okay. That was the same question. Oh, this sounds like I know we're probably I think he said we can go over like 5 minutes, because this is intriguing me. I am a recently minted bondodontist, new to SDF or new to smart SDF strip crowns. I recently treated a 4-year-old with SDF on the maxillary anteriors, followed by strip crowns at a later point. I attempted to move the surface layer with a slow speed carbide and restored with resin, but the SDF showed through. Indeed it does. And the results were not aesthetically pleasing. What materials should I use to mask the SDF better? Well, honestly, with a lot of these now, like if it's not a total sweaty nightmare to work on them, like if I can get them still, I would maybe just do one Equia strip crown at a time minus the SDF. So there'll be no stain and you'll get a ton of remineralization. But if it's after the fact and maybe initially all they want is SDF, or maybe they've already had SDF, or maybe SDF is the best that you can accomplish because they're so uncooperative, and now you're trying to mask the stain, usually you're going to have to prep some of that out. If they're at a point where they're like, okay, I'm cool with sedating, let's do zirconia crowns mask it quite well. But if you're doing like a strip crown, you're going to want something more opaque. So regular Equia Forte is more opaque than HT. But even with that, sometimes some of the dark can show through. So some parents might be okay with that if you can do it in an atraumatic fashion, if they still don't want sedation. Otherwise, you might have to still prep some of the stain out so that you have enough depth for enough bulk of the Equia to mask the SDF stain. So I hope that helps. Thank you for admitting that you're a minted bond. I'm a recovered bondodontist myself. Okay. Someone's having problems with their Equias are fracturing and mentioning how there's increased stress and bruxing this past year with the pandemic. I think we've seen that in general, period. So I don't know if you were using Acquia for a long time before the pandemic, but natural teeth are breaking, resin treated teeth are breaking, crowns are like, I don't necessarily think it's the Acquia. Now, if you're newer to Acquia, like when the first 6 months I used it, I didn't really know what I was doing, and I was letting some dry out or I was overworking them, and I definitely had some pop out and fracture. But luckily, none of them had recurrent caries or sensitivity. So I just put more Acquia. But yeah, but if you have a real bruxer, they might need a guard or something. Maybe they need a crown. Okay. And then someone asked about using SDF as an indirect pulp cap. I don't personally prep a tooth and then put SDF. Some people do like putting it under their crowns. I don't routinely do it because I get good sensitivity and remineralization with just using my glass cement. All right. And we are out of time. Okay. Thanks so much for tuning in. Everybody have a great night and take care.